Okay. Mm, anyhow, some of the software is not working. Okay, student. Good evening, students. I think this is the third class on retina. So today we will cover only some of the small topics. Those are actually miscellaneous topics, but they are very important with regard to the exam is concerned. So we begin with one small MCQ question. Then we'll cover some of the topics. A soft exudates are seen in which layer of the retina? Options are ganglionic cell layer, outer plexiform layer, inner nuclear layer, and nerve fiber layer. What is the answer? Anybody? This was covered in the last class, previous class. Anybody? Students? Okay. The answer is see, the soft exudates are nothing but if you soft exudates, the other name is cotton wool spots. Normally, why it happens? The cotton wool spots occurs due to the ischemia of the ganglionic cell layer. Whenever any insult on the ganglionic cell layer in the form of ischemia, the ganglionic cell layer will give rise to the what you call axons. Whenever there is any ischemia or death of the ganglionic cells, there will be stasis of the exoplasm. Okay, that give rise to the dirty white or a yellowish white exudates known as the soft exudates. See, other types of lesions in the retina are one is a dot and blot hemorrhage, which is seen, which are basically the deep hemorrhages, which are seen in the inner nuclear layer. Similarly, the superficial flame-shaped hemorrhages are seen in the ganglionic cell layer. Okay, they have a flame-shaped architecture. Similarly, you have microaneurysms which are present in the inner nuclear layer. Okay, so uh, what are the cause for soft exudates? Okay, what are the differential diagnosis for the soft exudates? As we know, soft exudates are the cotton wool spots. The most common ones are any disorder which causes the ischemia of the retina will give rise to soft exudates. Examples, the most common ones are diabetic retinopathy, hypertensive retinopathy, followed by again a toxemia of pregnancy. Again, it's a hypertension, malignant hypertension, pheochromocytoma, AIDS, CME retinitis, SLE, polyarteritis nodosa, CRVO, central retinal vein occlusion, especially the ischemic type, okay, will give rise to soft exudates, radiation retinopathy, and anemic. Any anemic conditions will give rise to soft exudates. Even the cardiac emboli will give rise to soft exudates. Coming to the next topic, that is the hard exudate. What are the differentials for a hard exudate? In which conditions you see hard exudates? Hard exudates are nothing but the collection of lipoproteins and the proteinaceous material, normally due to the permeability, increased permeability of the retinal vessels. The most common causes are the diabetic retinopathy. Okay, one should not forget at any cost. It's a diabetic retinopathy, which is the most commonest cause, followed by hypertensive retinopathy. Similarly, you have choroidal neovascular membrane. See, all these topics are covered in the last two classes. So we should know what are the causes for the hard exudates. I'm not going into the details because, as I told you, this has been covered in the previous classes. Choroidal neovascular membrane, that is the most one of the most commonest cause for a hard exudates. Similarly, the Coats disease, that is the a peripheral telangiectasia of the blood vessels, which is seen in especially a small around 10 to around around 10 years of the age, where you will see hard exudates followed by exudative retinal detachment. Similarly, you have phacomatoses, that is the von Hippel-Lindus disease, where there will be telangiectasia of the vessels, which give rise to the hard exudates. CRVO, which is a non-ischemic type, will give rise to hard exudates. And radiation retinopathy and retinal other retinal vascular disorders. Okay. The next topic is CME retinitis. CME retinitis, why it's important? Because this is the most commonest cause for a retinitis in a HIV patients. Okay, you should not forget. Again, this is a many times this question has been asked. So, which is the most commonest opportunistic infection? Retinal infection in a case of HIV patients, that is the CMA retinitis. And what is the most commonest finding, clinical finding in the retina in a case of HIV? That is the cotton wool spots. Okay, that also I covered in the last class. So, how exactly, what are the other names for the CMA retinitis? The other names are, let's say, crumbled cheese or a ketchup appearance, or pizza pie appearance, or a brush fire appearance. Okay, these all three terminologies are very important. They might ask in the exams. And how do you diagnose a CMA retinitis? One is based on the clinical appearance, and how do you conclude the diagnosis? By doing a PCR. So most accurate method is, if you take any fluid from the vitreous cavity or from the anterior chamber, and if you that subject for a DNA, what you call the PCR, especially the DNA detection by a PCR is the most accurate and the rapid method for diagnosis of a CME retinitis. The next will be, what are the ocular manifestations in a case of HIV patients? Okay, you can start from the skin till the optic nerve. You have all the different manifestations, and you should remember this chart. This is very important because the ocular diseases depends on the CD4 count, and normally if you take, we divide like 250 to 500, 150 to 250, 50 to 150, then less than 50. The most commonly asked one is when the CD4 count is less than 50, CME retinitis is the commonest infection. Okay, you should not forget. And if you start from, and they tend to have, these HIV patients tend to have lymphomas, especially the non-Hodgkin's type of lymphoma, also known as a Burkitt's lymphoma. That is very commonest lymphomas which is seen in HIV patient. In the skin, you see Kaposi sarcoma followed by molluscum contagiosum. That is also one of the most commonest what do you call cutaneous infections in HIV patients. Okay, and some of the other different manifestations or different presentations in the retina are salt and pepper retinitis. In which are all the conditions you see salt and pepper retinitis. Again, these topics are based on what previously asked in the entrance exam. So we've taken some of the topics and what are the cause for that we'll discuss. See, if you look at the fundus, normally you don't see this, black, a pepper like, the appearance of the retina. This is due to the pigmentation. Okay, this is seen most commonly in a congenital syphilis, congenital rubella, and phenothiazine toxicity, and fundus flavum maculatus. This is one of type of dystrophies, fundus dystrophy, and this we will cover it later in this class. But you should know what are the cause for the salt and pepper retinitis. So exactly how it looks, you have a pigmentation dispersed all over the fundus. Next, you have a bullseye maculopathy. What is bullseye maculopathy? You have a pigmentary changes in the macula, not at the equator or in the periphery. And this, when you do a fundus fluorescein angiogram, it looks like a bullseye, you know, like a bullseye. This is known as a bullseye maculopathy. So what are the causes? Recently, we know in a COVID, one of the first earliest treatment that was proposed in coronavirus infection was the HCQS, okay, hydroxychloroquine. That was, so that actually that if you take it for a longer time, that is known to cause bullseye maculopathy. Okay, chloroquine, especially the chloroquine and its derivatives like HCQS, that is hydroxychloroquine, and also clofazimine, are known to cause bullseye maculopathy. Okay, other causes are cone dystrophies, especially the dystrophies which affects the cone in the macula are known to cause bullseye maculopathy. And you have a Stargardt disease. Stargardt is again, type of juvenile what you call the retinal dystrophy, where the age between 10 to 20 years of age, where there will be lipofuscin deposits at the retinal pigmented layer. That I will show you the photograph how it looks, but you should remember what are these are the more, there are so many causes, but for your examination point of view, for at least for the UG level, you should know these four the most important cause for a bullseye maculopathy. Then coming to the next one, that is a age-related macular degeneration. So what are the pathogenesis in a case of age-related macular degeneration? Sorry, the pen is not working, or else I would have showed exactly how it appears. Anyhow, you should know, suppose this is the retinal pigmented epithelium. These are, outer segments of the photoreceptors. Okay. So in a case of, suppose a patient is exposed to a more light, or due to external factors, maybe due to, excessive oxidative stress or genetic, predisposition, these will lead to what you call the increased metabolism of the outer photoreceptors. Okay. Whenever there is an increased metabolism, okay, there will be waste products. These waste products will be excreted between the retinal pigmented epithelium and the Bruch's membrane. Okay, these excreted what you call waste products are drusen. For a UG, you should know this much. Drusens are nothing but an excretion from the metabolites of the retinal pigmented epithelium. These will induce inflammation. Whenever there is an inflammation, normally the Bruch's membrane is, normally it's very fragile and it's flexible, elastic. But because of inflammation, this Bruch membrane becomes what you call calcified and stiff. Whenever there is a break in the Bruch's membrane, choriocapillaries percolates and they will divide to form the neovascular membrane. Okay, that is a choroidal neovascular membrane. Whenever you find only the drusens like this, okay, a well demarcated yellowish dot are nothing but the dry ARMD. We call it as a dry ARMD. When the drusens, if you see only the yellow white spots, exactly they are present in the macular area, they are known as dry ARMD. Whenever there is a greenish, yellowish green membrane which is present beneath the retina is the choroidal neovascular membrane. Okay, this is the histopath, how it looks exactly in a case of ARMD. So in a ARMD, this is that is the drusen which is deposited between the RPE and the Bruch's membrane. So how do you treat? What is the treatment for this? In a case of dry ARMD, there is no proven any treatment for this, but the antioxidants are known to halt the progression of the ARMD, and with a limited success, antioxidants have been tried in the case of dry ARMD. Okay. Coming to the next, that is the wet ARMD, also known as a choroidal neovascular membrane, secondary to ARMD. So in the previous classes, we discussed the wet ARMD or a choroidal neovascular membrane. The treatment is because there is a vascular endothelial growth factor upregulation, we give anti-VEGFs. And the anti-VEGFs that we have discussed in the last class, that you should remember. So in a case of wet ARMD, we give anti-VEGFs. In a case of dry ARMD, though the efficacy is not proven or the poor, the treatment is what you call the antioxidants. Next, coming to the next topic, that is the retinitis pigmentosa. Retinitis pigmentosa is one of the commonest inherited retinal disorders. If you take any of the disorders, whether it is Stargardt's, cone dystrophies, or macular dystrophies, but the retinitis pigmentosa is very commonly occurs in all the age groups, and you should know normally it affects the rod. Okay, this affects the rod. Because it affects the rod, we know that rods are responsible for the dark dim vision in the dim light, and cones are responsible for color vision or in a daytime vision. Okay, whenever the rods are affected, because the rods are distributed in the mid periphery. Okay, so whenever the rods are affected, the patient will have a poor vision in the night time. Okay, in the dim light they will have a very poor vision because the rods are not functioning. That you should know. That is the one of the earliest clinical presentation in a case of retinitis pigmentosa. They will present with the night blindness. Okay, so what are the causes for retinitis pigmentosa? We have the 50% of the cases are due to unknown reason, that is idiopathic. Rest of the 50% are due to inherited. The causes are autosomal dominant, autosomal recessive, or it's a X-linked type. But how do you differentiate? What is the importance of knowing whether it is autosomal dominant, autosomal recessive, or X-linked? Autosomal dominant has a late presentation. It's a milder variety. Okay. Next is the autosomal recessive. This is in comparison to autosomal dominant. Definitely, it's slightly severe than the autosomal dominant, but it has a little bit early presentation. But out of three, the most severe form is a X-linked one. Okay, X-linked type of retinal pigmentosa is known to cause a very severe loss of vision. Along with that, the patient will have a very early presentation. Okay. Next, there are less than majority of the cases, around two-thirds of the cases are isolated condition. That means whenever you see a patient with a retinitis pigmentosa, you don't see anything else. Apart from that, you don't see any other systemic features. But in less than 25% of the patient will have some sort of systemic association. That I'm going to cover it in the next few slides. What other ocular features? This question was asked in our fellowship exam. What are the other ocular associations with the retinitis pigmentosa? You should know that can cause a keratoconus. Then you have a posterior cataract for you, at least for the UG level, posterior subcapsular cataract, myopia. Then you have cystoid macular edema. Okay, these are the four important things that is seen in a case of retinitis pigmentosa. Apart from that, what are the clinical presentation? They will have a night blindness. If you do a visual charting, they will have something known as a ring scotoma. Okay, ring scotoma is a one thing I will show you because we don't have pen. I will show you how it looks. How the this is the best picture. Can you see this? Okay. This is the visual field. This is the visual field. Within the visual field, suppose, okay, this is the best thing. Suppose this is the black thing is nothing but the optic disc. Okay. That is the absolute scotoma part. Because I told you, right? Suppose this is the disc, and around the disc you have a equator. Because the retina rods are distributed along the equator, when the rods are affected, that will cause a ring scotoma. Okay. And if you look at the fundus photograph, if you look at the fundus photograph, the vessels will be, narrower than the normal fundus. Okay. And along with that, the optic disc, which is normally which is pink in color, if you look at this, this will be waxy and pale in color. Okay, and these black dots are nothing but atrophy of the rods, which is replaced by the hyperpigment, the RP cells proliferation, known as the bone specules. Okay, jet black bone specules are hallmark of a retinitis pigmentosa, which is distributed at the equator. Give me 5 minutes. I think it got stuck, I think. Okay. What are the What are the other RP associated, retinitis pigmentosa associated syndromes? What are the syndromes we have? Okay, so we have Usher syndrome, Bardet Biedl syndrome, or a Lawrence Moon Biedl syndrome. Both are same. Then you have Kearns-Sayre syndrome, mucopolysaccharidosis, which are basically the glycogen storage disorders, especially the 1, 2, 3 are main important types which are associated with retinitis pigmentosa. Then you have A beta lipoproteinemia and Refsum disease. So let's discuss one by one how they are different from one another. In Usher syndrome, there will be sensory neural hearing loss. Along with that, the patient will have a retinitis pigmentosa and vestibular imbalance. Okay, these are the main important features in a case of Usher syndrome. Then you have Bardet Biedl syndrome or a Lawrence Moon Biedl syndrome. What are the features? You have obesity, short stature, polydactyly. I will show you the photograph. Okay, if you look at this photograph, I don't think you'll forget. Patient will have obesity, they will have a short stature, they will have a polydactyly. Can you see here? There are 6 fingers. All the 4 extremities will have a 6 fingers. Okay. This is a polydactyly. Apart from that, they will have a pigmentary changes in the retina. Retinitis pigmentosa they will have, and they will have a hypogonadism and diabetes insipidus. Okay. Then you have Kearns-Sayre syndrome, where there will be mitochondrial DNA deficiency, which results in sensory neural hearing loss. CPEO. What is CPEO? Chronic progressive extraocular ophthalmoplegia. And they will have retinitis pigmentosa, cardiac defect, and CNS disorders. See, the extraocular muscles, because there is a DNA deficiency in the mitochondria that affects the extraocular muscles. All the muscles will get paralyzed. The patient will have, there will be drooping of the eyelid, okay, and all the muscles will be paralyzed. Similarly, they will have a periventricular calcification, which is this is a hallmark in a case of Kearns-Sayre syndrome. They will have a retinitis pigmentosa, sensory neural hearing loss, and when you do this, when patient present these symptoms, always subject the patient for cardiac investigation, because they will have conductive cardiac defect. Okay, and they will have ataxia or seizures. Then you have A beta lipoproteinemia. The other name is the Basson-Conway syndrome, where there will be genetic defect in the chylomicrons, which normally carries the lipid and the fat. That chylomicrons will be defective. There will be reduced LDL level. Okay, in these patients, they will have, because there is a reduced LDL level, these patients will have a hepatosplenomegaly. Next is a Refsum disease. This Refsum disease, it's a there is a metabolic disorder. There is a phytanic acid alpha hydrolase deficiency. Whenever there is a deficiency of this enzyme, obviously you can make out there is an increased accumulation of a phytanic acid. Whenever any product which deposits in the body, there will be hepatosplenomegaly, they will have cardiomegaly because of deposition of these phytanic acids. Okay, so let us answer some of the questions. Cotton spots are seen in all except diabetes, hypertension, toxemia of pregnancy, HIV, and cytomegalovirus, retinoblastoma, and Coats disease. Any students attending? Anybody? Yeah.
Yes, sir.
Any guess? Cotton spots, right? See, we discussed cotton spots are seen in diabetes, isn't it? Diabetes and hypertension. Okay. Yes, this is yes, we do see in a case of diabetes and hypertension. Then toxemia of cotton spots. I told you, right? It's ischemia. Ischemia causes the cotton spots. Toxemia of pregnancy. Yes, it causes the cotton spots. HIV again. I told you, right? One of the earliest manifestations in the presentation in the retina is cotton spots. Then again in a CME retinitis, we do see cotton spots, but retinoblastoma and Coats disease. I told you, right? There is a abnormal dilatation of the vessels. So there will be hard exudates, not the soft exudates. Retinoblastoma is a intraocular. Most common a childhood intraocular tumor is the retinoblastoma. Here you don't see any soft exudates. Okay. So you will see a mass inside. So D is the answer. Okay. Any doubts? Next. Hard exudates are seen in all except diabetes mellitus, hypertensive retinopathy, Coats disease, central retinal vein occlusion, CNVM and retinal artery macroaneurysms. Then you have retinitis pigmentosa, Eales disease, SLE, toxemia of pregnancy. Anybody? This question was asked in PJ Chandigarh. Okay. So hard exudates are definitely, of course, it's seen in diabetes and hypertension. Coats disease, yes, because there is a abnormal tortuous vessels. In CRVO also we do see hard exudates. CNVM, yes, of course, there are new vessels and retinal macroaneurysms which are leaky will cause hard exudates. Retinitis pigmentosa, you don't see anything. It's a dystrophy. Eales disease, I told you last time, these are the vasculitis. Okay, the blood vessels will get sclerosed. Okay, especially the veins are involved. Phlebitis, the peripheral veins are involved. So the peripheral retinal veins are involved. That will cause a phlebitis that results in new vessel formation. SLE again will cause, doesn't, it's a vasculitis. Toxemia of pregnancy will cause soft exudates. Okay. Eales disease, in Eales disease, we see something known as, in Eales disease, we see something known as a C front. Okay. You go back and read what is that C front. Sorry, it's today, it's not working. Anyhow, you should know in RP, Eales disease, SLE and toxemia of pregnancy, you don't see hard exudates. Ocular manifestations of HIV are predisposed to viral, bacterial, fungal infection, Kaposi sarcoma, cotton wool spots, intraocular lymphoma. Anybody? Students? Again, this is a PJ question. I told you, right? All. It's predisposed to all bacterial, viral, and fungal infection. Apart from that, cutaneous manifestations are Kaposi sarcoma. Cotton wool spots on the retina is the most common clinical presentation. Yes, intraocular lymphoma, especially the non-Hodgkin's type, are very common. So, therefore, All the four options are correct in this question. Commonest opportunistic organism to cause ocular inflammation in AIDS is, this is again a straightforward question. This we discussed: cytomegalovirus, toxoplasma, cryptococcus, histoplasma. So the answer is cytomegalovirus. That is the most commonest viral infection in the case of HIV patients. Sausage cheese retinopathy is seen in CME retinitis, rubella syndrome, toxoplasmosis, congenital syphilis. In a case of rubella, you see salt and pepper retinopathy. Toxoplasmosis, you see, what is that? Headlight in fog appearance because of a severe vitritis, isn't it? That we discussed in the last class. Then you have a congenital syphilis. Congenital syphilis will cause again salt and pepper retinitis. Along with that, there will be interstitial keratitis. But CME retinitis will give rise to brush fire appearance or pizza pie appearance or a sausage cheese retinopathy. Macular involvement is seen in toxoplasma, malaria, CME retinitis, and syphilis. You know that in a case of malaria, malaria normally causes just a retinitis. But if you look at this, CME retinitis doesn't, it involves the vessels. Malaria also involves the vision. But even the syphilis causes the retinal, peripheral retinal involvement. But in a case of toxoplasma, there will be macular involvement. Okay, macular chorioretinal scar formation that is seen in a case of toxoplasmosis, and it involves the macula. The most rapid and accurate test to diagnose CME retinitis: virus isolation in an intraocular fluid, virus nucleic acid detection in an intraocular fluid, viral antigen detection in a vitreous, viral antibody detection in a blood by ELISA. Again, this is a straightforward question. The answer is B, that is a detection of nucleic acid, that is the DNA detection by PCR method, the fluid which is taken from the intraocular content. Salt and pepper fungus is seen in, anybody? Multiple sclerosis, cystinosis, Weil-Marchesani syndrome, congenital syphilis. Anybody attending?
Congenital syphilis. Option D, sir.
Yeah, very good. And one more thing you should know, because all options are very important with respect to the exam is concerned. Again, cystinosis. In the cystinosis, what happened? There will be, in a cystinosis, there will be deposition of the cornea. Okay, remember this, C for C. Okay, cystinosis, there will be cystine is the amino acid which is excessive in nature, with metabolic disorder, which is deposited in the cornea like a crystals. Okay, that is a cystinosis. Then you have a Weil-Marchesani syndrome. This is very similar to Marfan syndrome. Okay, Marfan syndrome, there will be ectopia lentis, isn't it? Similarly, in a case of Weil-Marchesani syndrome, you have a ectopia lentis. But if you look at the clinical features between a Marfan syndrome and a Weil-Marchesani, Marfan syndrome, the person will be, you will be very tall, slender, you will have, but if you look at the Weil-Marchesani, they will be short, they will be obese. Okay, and again they will have a ectopia lentis. Along with that, in a Weil-Marchesani, you will have a microspirophakia. What do you mean by microspirophakia? Microspirophakia means the lens will be small. Because it's very small, it becomes like a spear. Okay, that is a microspirophakia. Along with that, there will be ectopia lentis, which is seen in a Weil-Marchesani syndrome. But in a congenital syphilis, you have an interstitial keratitis and you have a salt and pepper retinopathy. Which of the following causes bullseye maculopathy? Anybody?
Chloroquine.
Yes, very good. Okay, you should not forget. Again, this might be one of the potential question, because in corona, one of the treatment option in the earlier days that was proposed was hydroxychloroquine, HCQS. Okay, and you take HCQS or a chloroquine or clofazimine, That is known to cause bullseye maculopathy. Okay. But whereas if we take isoniazid and ethambutol are known to cause optic neuritis. Okay. These are the antitubercular drugs are known to cause optic neuritis. Steroid is known to cause secondary glaucoma and a cataract. Dapsone is given is an antidepressive drug. Deposits in the retinal macular degenerations. Again, this we covered. What is the type of deposition in a case of age-related macular degeneration? Students, options are iron, drusen, lipochrome, and hemosiderin. The answer is drusen, isn't it? We just now we discussed age-related macular degeneration. It can be dry type or a wet type. Dry type, there will be drusen deposits. In a wet, there will be choroidal neovascular membrane formation. Okay. What is this hemosiderin? Hemosiderin is seen whenever there is any, especially trauma. Okay, trauma will cause uh, the anterior chamber hematoma or hyphema that will get deposited on the corneal endothelium or on the iris, or in a case of intraocular iron foreign bodies will cause hemosiderin deposit on the retina. Okay. What is PDT? PDT is used in the eye for the following disease. Okay. First you understand PDT means photodynamic therapy. Photodynamic therapy means there this is used in a case of wet ARMD. Whenever there is a choroidal neovascular membrane, we use a photosensitizer, that is a vertiporphin. Okay, vertiporphin is a photosensitizer, a chemical agent which is used, which is injected intravenously. Whenever this intravenous solution comes into the eye is lasered using a diode laser. Okay, when this solution takes the laser, okay, that will cause the destruction of the choroidal neovascular membrane. This was the treatment 10 to 15 years back for a wet ARMD, but now the current treatment option is the vascular endothelial growth factors. Okay, so the PDT used in the eye for the following disease, that is the wet ARMD. Retinitis pigmentosa is due to defect in which gene? Anybody?
Scotopsin.
No, it's a rhodopsin. No, there is nothing like scotopsin. It's a rhodopsin. Okay.
Rhodopsin, sorry, sir.
Yeah, rhodopsin. Scotopsin is found in where? Which is present in the cone, right? Okay. Rhodopsin is present in the rods. So the rods is responsible for the dim light. Scotopsin is responsible for the color vision and the daylight. So there is a defective gene which encodes the rhodopsin is seen in a retinitis pigmentosa. RP is a feature of all except Refsum disease, Haller-Boydum Spatz syndrome, A beta lipoproteinemia, and NARP. NARP means neuropathy, ataxia, retinitis pigmentosa. Again, very simple. What is the answer? We discussed, right? Refsum disease, phytanic acid deficiency with RP changes, which is seen, but this is not seen. Okay. Again, you have A beta lipoproteinemia, also known as a Basin Conway syndrome, where there is a deficiency of the chylomicrons and decreased level of LDL. Okay, that will cause Basin-Conway syndrome. Then, as the name suggests, whenever RP comes, you should remember this. Okay, RP is a standard abbreviation for a retinitis pigmentosa. Neuropathy, ataxia, and retinitis pigmentosa is a feature of this syndrome. So this is also RP seen in this also. Okay, so the answer is B. Which enzyme is defective in Refsum disease? Anybody?
Option A, phytanic acid.
Yeah, good, very good. Okay, so straightforward again. If you know the answer, you can answer. Phytanic acid, alpha
Alpha
hydrolase
hydrolase.
3, yeah, is the enzyme which is deficient in a case of Refsum disease. RP is associated with all except Usher syndrome, Marfan syndrome, Kearns-Sayre syndrome, Basin-Collins syndrome.
Marfan syndrome.
Yeah, Marfans. What are the features in a Marfans? Hope you people by this time you're well
Temporal.
versed with Marfans, isn't it?
Yes, sir.
Okay. Yeah. And normally, what is the where? What is the location of the ectopial lentis?
Superior temporal.
Very good. And what is the reverse of this?
Homocystinuria. Something.
What is the direction of
Inferonasal.
ectopial lentis? Huh?
Inferonasal.
Very good.
Inferonasal,
Okay.
sir.
Well, good, good. Intranasal. All are true about retinitis pigmentosa except it's genetically inherited, that is X-linked. Early diagnosis and treatment prevents the progression. Visual acuity is not diminished till the late in the course, associated with systemic abnormalities. What is the answer?
I think there is no involvement of systemic.
Huh?
Systemic involvement is not there.
Why? It's there, no? We discussed so many. Do you think the B is the
Yes,
correct answer?
sir, yes, sir. RP
Do you think the B is the correct
associated
answer?
syndrome.
Hello?
No, sir, no. Early
See?
presentation also there. No, sir.
Okay. Early diagnosis, first of all, it's a genetic disorder. Okay. It's an irreversible condition. So it doesn't have any treatment. There is no proven treatment till now. Okay. Till date, there is no proven treatment. So early diagnosis and the treatment prevents the progression. That is the correct answer in this question. Okay. Genetic inheritance, yes. It can be autosomal dominant, autosomal recessive, or X-linked. That is the correct answer. Visual acuity is not diminished till the late in the course because the macula is not affected, right? This affects only the equator. So they will have a tunnel vision. They will, till the advanced stage, they will retain a good vision. That means they will have good 6 by 6 vision, but they might have lost the peripheral vision. Okay, that is known as a tunnel vision, as if the patient is looking through the tunnel. Okay, central vision will be perfect except for the peripheral vision, which is lost. So that is also correct answer. Associated with systemic abnormalities, we discussed a number of the syndromes which are associated with retinitis pigmentosa. A patient presenting with peripheral field loss and a fundus examination shows waxy exudates and a pale disc with pigmentation around the vessels. A diagnosis again, I told you waxy exudates, pale disc, pigmentation around the vessels, especially the peripheral field loss. Okay, that goes in the favor of retinitis pigmentosa. In an open angle glaucoma, you will have a central loss of vision, isn't it? Okay. Sorry, sorry. Open angle glaucoma again and retinitis pigmentosa, you will have what you call the the central vision will be retained till the advanced stage, but in a case of glaucoma, you will have pain, the other features. Chorioretinitis definitely is not, you don't see any waxy exudates or a pigmentation around the vessels, but chorioretinitis, you will have a well demarcated a patch of a scar. Okay, so the answer is retinitis pigmentosa. Fundus in a retinitis pigmentosa is white spots with a red disc, jet black spots with a pale waxy disc, no pigmentation, dilatation of the arterioles. Again, it's a straightforward. A jet black spots, also known as a bone specules. Okay, with waxy disc is the hallmark in a case of retinitis pigmentosa. We do see pigmentation, but vessels are narrowed. Okay. Most characteristic finding of a retinitis pigmentosa is a ring scotoma, field defect, central scotoma, or diplopia. What is the answer?
Ring scotoma.
Yes, you should not forget. Okay. Ring scotoma. Field defect. What do you mean by field defect? Anybody? Field effect you see in a case of like hemianopia that we will discuss when we discuss about the neuro-ophthalmology. Okay. Field effect means hemianopias. Okay. Maybe it's a bitemporal, homonymous. Okay. Normally what happens when the visual tract is affected, when except for the retina, visual tract is affected from the optic nerve, optic chiasma, optic tract, optic radiation. If anything is involved, you will have a field defect. That means any hemifields are affected. But a central scotoma you will see in a case of age-related macular degeneration because the macula is involved. So you'll see central scotomas, central defect. Central vision is lost. Diplopia you don't see. Diplopia is a normally in a case of any muscle weakness due to any palsies of the nerves. Okay, so the ring scotoma is a hallmark in a case of retinitis pigmentosa. In RP, the following are true: pigment present, pale waxy disc, narrowing of the vessels, ERG normal. What is ERG? Anybody? ERG refers to electroretinogram. Okay, similar to you have a EEG, right? Electroencephalography or an electroencephalogram. In that, you record the electrical discharge from the brain by placing the what do you call electrodes on the skull. Similarly, we record the electrical activity of the retina by placing the electrodes on the skull. Okay, that is known as the ERG. So normally, whenever suppose in a case of retinitis pigmentosa, because the neurosensory pigments, what you call the photoreceptors are lost, so definitely they won't elicit any electrical activity. So obviously the ERG, electroretinogram, will not be normal, at least in a case of dark adaptation. Again, the ERG can be dark adapted or it can be light adapted. Dark adapted will be subnormal in a case of retinitis pigmentosa, depending upon the stage of the disease. So of course, so therefore it can't be normal. Other things are absolutely correct. Pigment present, pale waxy disc, narrowing of the vessels. So the option here, the correct answer is D, that is a ERG normal. Okay, hope you understood. Idiopathic nyctalopia is due to hereditary, and the cause is absence of rod function, absence of cone function, absence of rod and cone function, decreased cone function. Again, this is based on your common sense. Okay, what is the answer here? What is what do you mean by nyctalopia?
Loss of night vision.
Yeah, very good. Okay, night blindness.
Night
Okay.
blindness. Absence of rod function.
Okay. Opia means basically the blindness. Nyctalopia means it's a night blindness. So the photoreceptor which are responsible for the dark light, dim light vision is the rod. Okay. So it's basically the absence of the rod function which give rise to idiopathic nyctalopia. Okay. Miso phenomenon is seen in, okay, the options are choroideremia, Oguch's disease, fundus flavimaculatus, fundus albipunctatus. Okay. Before answering this question, I will show you some of the slides. You hope you'll understand and you'll be able to answer the question. Oguchi's disease is a type of, congenital stationary night blindness in which what happens normally if you look at this fundus, okay, you just compare, both are not normal, both are not similar. Look at the color, this is dark in color, this is brighter in color. Okay, this brighter color is known as a golden yellow color. This is due to a pigment, golden yellow pigment deposits, which is seen in a case of Oguchi disease. Oguchi's disease is a type of congenital night blindness, okay, where you will see yellow, golden yellow pigment deposits on the fundus. Okay, so whenever these patients are exposed to a dark light or in a dim light, after normally what happens within 30 minutes, you should be able to regain the vision in a dark adapted condition. But in a case of Oguchi's disease, because of the night blindness, even after 30 minutes, they won't recover and they will have a poor vision, and the color will change here from a bright golden yellow color to a dark color. Okay, this phenomenon is known as a Mizuo phenomenon. Okay, this is known as a Mizuo phenomenon, which is seen in a Oguchi's disease. Next, you have other options like choroideremia. What is choroideremia? You don't have to go into the details, but you should know what are the just a definition of it for the UG level. See, in the choroideremia, as the name suggests, normally what happens? There will be atrophy of the choroid, especially the choriocapillaries. Along with that, choriocapillaries supplies the blood to the RP cells and also the photoreceptors. Once all three structures are lost, you will have only the sclera and you will have a choroidal larger vessels. Those are visible. Can you see here? You have a white background sclera, then you have a large vessels. These are the choroidal vessels. Along with that, you have a retinal vessels. In the macula, you will see a little bit of pigmentation. This is known as a choroideremia. Apart from that, the other option is a fundus albipunctatus. Again, this is a type of retinal, pigmentary changes, which is seen in the periphery of the retina, like a white dots. White dots, albipunctatus. That's how you remember. Then you have the fourth option, that is the fundus flavimaculatus, also known as a Stargardt disease. In a Stargardt disease, I told you, right? In a Stargardt disease, that is also one of the cause for a bullseye maculopathy, isn't it? Can you see here? Even the macula is involved. Here what happens? There will be lipofuscin deposit at the RPE level. This is known as, again, this is very important for the exam, that is a beaten bronze appearance, okay, or snail slide appearance. Can you see here? Like a beaten bronze appearance. These are the yellowish lipofuscin deposits, which is seen in the case of fundus flavimaculatus. Okay, so with this, you should remember what is Oguchi's disease and where do you see that Mizuo phenomenon. With this, today I conclude my talk. Next class will be on retinal detachment. That will be the last class for retina. After that, you people suggest what is the topic needs to be covered, at least as a priority. Then we will go accordingly. After that, once you have a time, we will cover the other topics. Let me know what are the difficult topics you would like to know. So we will cover that part after one more class. Retina, we have one more class. After that, you suggest me what are the classes needs to be taken. Okay. Thank you. If you have any doubts, let me know.
No doubts, sir.
Thank
Thank you,
you.
sir.
Ah.